Good evening. I am Dr. Hani Hafiz, Professor of Nephrology at Cairo University. And it is my honor today to be the chair of this important session of kidney transplantation, new possibility, endeavoring new possibilities in collaboration with Sandoz Company. And before we start, I would like you to have a moment of silence in respect of the soul of our dear friend and colleague, Professor Hussein Shaisha, who was the president of the Continuous Medical Education chapter in our Egyptian Society of Nephrology and Transplantation, and who died last Saturday. Please have a moment of silence before we start. Thank you very much. In this evening, we are privileged to have very important international speakers. Professor Joliot Pascual, of course, Professor Joliot is the head of the nephrology in Hospital del Mar at Barcelona. And I personally attended his work last year. And he will be our first speaker, followed by Professor Christophe Legendre. Professor Christophe Legendre is the head of nephrology at Paris Descartes and the head of the adult nephrology and transplantation at Necker Hospital. And also I got the privilege of working with Professor Christophe Legendre 20 years ago when I was a fellow, and I worked at Necker for 1.5 months in his companionship. After that, we will have Professor Tarek El-Baz, the president of the Arab Society of Nephrology and Transplantation, followed by Professor Frank Dorr from United Kingdom, and Professor Tariq Fayad, professor of nephrology at Cairo University, then Dr. Georgia Jordan from UK again. So it's a night full of science, and I hope that all the participants will get benefit from the knowledge that we will have, and many of this knowledge will be presented to the soul of our dear friend Hussein Shaisha, who was very keen to attend such important scientific gathering. Now we will go waiting for Professor Joliot Pascual first presentation.
Good evening to all of you, ladies and gentlemen. Thank you very much for being here. First of all, I would like to thank the organizers, Dr. Hafez and Sandoz, by sponsorship this webinar session with so great friends and experts in transplantation. And the commitment I have today is to share with you some concepts on the underlying diseases and infections, and of course other complications that can come with kidney transplantation. This is the outline for today. I will do some introduction. All of you that know me know very well that I like to share this concept of expanding the indications and the access. Just said, for me, kidney transplantation is the best renal replacement treatment. It gives the kidneys that you can imagine from deceased donors. This is better than dialysis. This is a paper we did 5 years ago from the Catalonian registry showing the patient survival of those patients in the waiting list for kidney transplantation that got a kidney, and those that remained in the waiting list for years, and the difference between both subgroups of patients, so those getting the transplantation with a black line, and those not getting it and remaining on dialysis for a given period of time in gray line, showed a very significant difference that was significant since year one. So during the first months, it was not the case of a better survival, but it was after the first year. We fortunately were able to confirm this in a very recent paper in Transplantation, showing that the relative risk of death at 1 year after kidney transplantation in those donor age groups, 60 to 79, and even above 80, because we in Catalonia had 128 recipients of over 80-year-old kidneys, showed a very significant protection from death if you get a kidney in comparison of remaining on hemodialysis. And it was clearly significant after the first year, after day 360, as you can see here, and maintained throughout the evolution. One very important document that came out during the last weeks was the Kidney Disease Improvement Outcomes, KDIGO, Clinical Practice Guidelines. And I will refer to this paper, which is published in Transplantation, in a full-length paper in a supplement, and in an executive summary in an article in the journal for these and other concepts. First of all, I would refer to who should be excluded. And in my opinion, in opinion of many physicians in transplantation all over the world, we should exclude few patients from transplantation, fewer and fewer as times go by. Those with very important non-adherence, those with active infections, those symptomatic and soft ischemic heart disease, those with severe lung disease, those with morbid obesity, or those with persistent malignancy or recently cured. And we have exceptions even for this difficult population. And despite that, we have too many excluded patients. And we need to do additional efforts to avoid classical inequities, those advanced age patients that are excluded only for age, women, which are more excluded than men, Black race and minorities, ethnic minorities, low economic incomes, rural areas, etc., are systematically excluded from transplantation in many areas. Every single kidney transplant unit should have written protocols for listing these patients. The patient should receive throughout information about the different options, and every patient should be periodically reevaluated for inclusion or exclusion from the list. As per KDIGO guidelines in 2020, the concept of the cause of end-stage kidney disease as an exclusion criteria, I have to tell you that after a lot of debate, underlying renal disease are not usually an exclusion reason or an exclusion criteria for these patients. Of course, there are risks of recurrence in many entities and many diseases that should be discussed with donors and recipients, and exclude patients only in some cases. For instance, if they are not effectively treated for multiple myeloma, light chain deposition disease, or heavy chain deposition disease, or AL amyloidosis, which is usually an exclusion criteria for having a kidney. But all those systemic diseases, FSGS, IgA, C3 glomerulopathy, etc., they have a variety of risk of recurrence that should be discussed, but usually they are not a complete exclusion reason or a contraindication for these patients. What about cardiovascular complications? You know perfectly that classical risk factors that we have studied when we were young are important and still are important. And we have, in addition to that, pre-transplant risk factors that are not that importantly reviewed sometimes: vascular calcification, chronic inflammation, endothelial dysfunction, etc. And of course, post-transplant risk factors all together are going to increase the risk for cardiovascular disease in this population: anemia, chronic infections, PTDM, immunosuppression, and persistent chronic inflammation. And unfortunately, many randomized trials for cardiovascular risk reduction have failed in kidney transplant patients. We know that ALERT trial, for instance, was a little bit successful, but not fully successful. We know that statin treatment reduces the risk of cardiovascular events in this population by 17%. And even the 2-year extension trial showed a little bit higher risk reduction. So statins should be probably prescribed for all this population and is probably under-prescribed in many, many patients. The favorite trial for folic acid didn't have any effect in cardiovascular event. And finally, the SECRET trial of candesartan improved blood pressure and decreased proteinuria, but it was stopped prematurely due to low event rate. So overall, the trials for cardiovascular risk reduction have not reproduced the good results in the general population with 10,000 patients that we have, and remain a debatable area that we should pursue in terms of good research in the future. And when beneficial effects are seen in many patient groups, are not extended to kidney transplant recipients. This is another good example some years ago, showing in a Lancet trial that ramipril was not superior to placebo in kidney transplant patients with proteinuria, and the composite endpoint of doubling the serum creatinine, end-stage kidney disease or death was not different between those patients receiving this ACE inhibition versus placebo, which you know perfectly that in the general population, this is very significantly better, and diabetic kidney disease, even the non-diabetic kidney disease. But finally, in transplantation, we are not able to reproduce these very, very important results in the general population. Diabetes, of course, is a key risk factor for cardiovascular events after kidney transplantation. So all the efforts focused on avoiding post-transplant diabetes should be reinforced, and low-dose steroids and low-dose tacrolimus are probably the most important factors to avoid these bad complications. What about the evaluation for the recipients that are in accessing the waiting list? You know that this is a very hot area of debate, and finally, in the KDIGO guidelines, the experts and finally a systematic review of the literature concluded that with a history, a physical examination, an electrocardiogram, and non-invasive screening is more than enough for patients without cardiac symptoms to access the waiting list. And if we detect an uncorrectable symptomatic patient, this should be excluded from the list. And of course, the guidelines are reinforcing the cardioprotection guidelines with aspirin, beta blockers, statins, and the PTDM prophylaxis, diet, low salt, etc., etc. And probably the main focus for today is infections. We are under a very, very hot pandemic with COVID-19, and the infections are a very, very important cause of death. In Spain, the mortality after kidney transplantation, if you put together all the cardiac and vascular reasons, of course, this cardiac, vascular, cerebrovascular, ictus, etc., probably are the best, the most important cause. But if you split these causes, finally, cancer and infectious diseases are the most relevant causes of death in this population. What about KDIGO guidelines in terms of infections? Delay kidney transplantation until active infections are solved. Asymptomatic colonization should not be an exclusion criteria by itself. So we can have some colonization with bacteria, with even some parasitides, and we should not exclude per se these patients. We need to do screening for the patients in HIV, HCV, HPV, cytomegalovirus, Epstein virus, herpes zoster, varicella zoster, the MMR, the HTLV and syphilis, and also in endemic areas, we should focus on strongyloides, Chagas disease, tuberculosis, and even malaria, depending on the endemic area. About vaccination, it should be similar to the general population before transplantation. And we, of course, have to delay a little bit leaf attenuated vaccinations. And in endemic areas, we need to focus on some important vaccinations, such as rabies, meningococcus, salmonella typhi, yellow fever, etc. What about COVID-19? I have to tell you that we have suffered a lot in Spain with these pandemics. We're suffering all over the world. You see Europe, how it is. You see the US, and of course, some Asian countries, etc. We had a first wave, which I named tsunami in the March and April months, in my hospital, which is a medium-sized hospital. Some of you know it. And we have 400 beds, and we have up to 100 admissions per day in March and April. It went down after the lockdown of the population at home during a couple of months. We controlled these pandemics in June. You can see it in the future. And finally, during the summer, it went up again. And we have, during the last 3 weeks, an important increase, which is not a tsunami, it's a surge. The sea is again moving, not as a wave that we had in March and April. We have learned a little bit about this infection. In the first cohort of patients, we saw in a multivariate analysis that the most relevant factors for mortality were advanced age, above 75, and especially above 85, was a very, very strong independent risk factor for mortality. And among the comorbidities, chronic kidney disease tripled, had a threefold increased mortality in comparison with non-CKD. So the chronic kidney disease, defined as a GFR below 60, had a threefold independent mortality risk than above 60 GFR, just only the yes or no CKD, not in a linear fashion. And it is not then surprising that the European registry, for instance, in 1,000 kidney transplant patients included, showed a 20% 1 month mortality. So during the admission for COVID-19, 20% of the transplant patients died. And it is really a high mortality rate, but it is not surprising given that CKD by itself is increasing a lot this mortality rate. This is the French registry with 2,043 patients published in Kidney International, showing that probability of severe disease at 1 month was almost 50% in the transplant population. And again, the 30-day mortality rate is 22%, with risk factors of advanced age, cardiovascular disease, and dyspnea as the main factors for death. The Spanish registry that we published in Transplantation a month ago showed that in 400 patients, we were able to identify 2 different phenotypes. Age, of course, was again a very strong risk factor, linearly here, as you can see, with very significant. Pneumonia and only respiratory symptoms was the most relevant factor for mortality. And on the contrary, gastrointestinal symptoms protected from mortality. So we saw a kind of benign phenotype with gastrointestinal symptoms and a fatal and much more dangerous profile with strong pneumonia in this population. Curiously, we saw a very high mortality during the first days or weeks after transplantation if the patient got a COVID-19. From March 17 to April 18, in 1 month, in Spain, we did 275 kidney transplantations. And 24 out of these patients, 9%, developed COVID-19. Half of them, 11 patients, died. And compared with survivors, they were older, they had earlier COVID-19 after kidney transplantation, most of them during the first couple of weeks. and it was less frequently treated with high-dose steroids. We didn't know at that time that dexamethasone high-dose steroids could be protective for many of these patients. And this was the situation in Spain. After having a mean daily number of transplants all over the country of around 100, it decreases during March to almost 0. And this was translated to our hospital, which has a monthly mean of 10 procedures, more or less. During March and April, we closed the program, given the very, very bad results that we have during the first pandemic weeks. And we didn't have good ICU resources for these patients after the operation, etc., etc. We didn't even have available good anesthesiologists for doing that in the hospital because of the immense number of COVID-19 patients that we had, and we closed for 2 months. Then after reopening of the program, you see that we got the 10 monthly activity, which is quite normal, despite that we still have COVID-19 cases. We have this algorithm for deceased donors. If the potential donor had previous COVID-19, we need at least 2 weeks and with a PCR negative to get these kidneys from the donor. And without previous COVID-19, we still need a negative PCR to get these kidneys. Of course, a positive PCR at this moment discard the donor in all cases. And these are national guidelines that we have today. And finally, tacrolimus is the key drug in kidney transplantation, but you know perfectly that toxicity is there. So we need to use low levels, and this is my mantra, this is my commitment to use low levels of tacrolimus. It has low bioavailability, high variability and fluctuation, so it is not an easy to use, but this drug even may have anti-coronavirus activity. We have some evidence that this drug could be even protective for the patients. So the incidence of COVID-19 is by no means increased in this population. Perhaps the severity is increased, but not incidence. So perhaps these immunosuppressed patients are protected from this cytokine storm that characterizes the bad patients that are admitted to ICU, etc. So in my opinion, it should be used as a standard of care in all patients transplanted now. We knew that before COVID-19, and we confirmed that the drug that we should prefer in these patients should be tacrolimus, even within the COVID-19 pandemic. This is some results in virus research 2012 in SARS-CoV, not SARS-CoV-2, which is not the cause of coronavirus 19, but previous coronavirus, showed that FK506 is able to block the replication, and the genome equivalence is decreased almost by 0 with these drugs in vitro. So perhaps tacrolimus has some protective effect against the replication. And on top of that, we know that everolimus has a very strong effect. You know my love for this drug and this mTOR inhibition. Of course, it is protective for viral infection. And overall viral infection in Transform trial, comparing TAC-MMF versus TAC-everolimus at 2 years, showed that the viral infections was 20% with everolimus and 35% with MMF. BK virus was 50% with everolimus and with MMF, and CMV infections was 4% with everolimus and 15% with MMF. And this is across all the prophylaxis you do, etc. We did a meta-analysis trying to see the benefits of mTOR inhibition combined with calcineurin inhibitors with 7,000 patients in 24 trials with different combinations, not only everolimus, but also sirolimus, and confirmed what is very perfectly known, that we had much less viral infections with mTOR inhibitors plus CNI. which a protection of more than 70% at 1 and 2 years. And if you add this notion to the convincement that we have that the kidney function is equivalent between both strategies, and we know this from the iBox, from the Paris group, showing that it is submitted for publication from Lucas group and the Transform collaborators in this, prediction at 10 and 11 years, showing the same kidney function for everolimus and MPA in comparison with reduced tacrolimus with everolimus and full exposure with MPA. And we tried to analyze, to assess the evolution of two small cohorts of patients, the pre-COVID period, January and February 2020, with 39 patients, and the COVID-19 period, or post, which is not post because we still have COVID, but after the first wave, 37% from May to August. And you see that age was a little bit lower because during the COVID pandemics, we decreased our aim or our impulse or our goodness for these old or very old, extremely old patients. You see that at the bottom of the slide that we had 4 COVID-19s with hospital admission in the hospital with 3 deaths, and we didn't have any death after only 1 COVID-19 during 3 months in the post-first wave COVID infection. So we have learned how to prevent that, trying to have a strict and clean pathways for these patients now, never mixed with potential to be positive, etc., etc. And in this way, we were able to reopen the program in May and had good results. And what about if your KT patient, your kidney transplant patients, develop COVID-19? In my opinion, you need to do early diagnosis and evaluation. You need MMF withdrawal. You need to maintain low levels, 5 to 8 at much, tacrolimus. And if taken everolimus, keep it at 3 to 5 and taper tacrolimus again to 3 to 5. So doing a 4 and 4 will be very nice for your patient. And of course, if the patient develops severe hypoxemic pneumonia, you have to treat it with dexamethasone, and no other drug is effective in our opinion, and all the disposable resources need to be put on board, including ICU for your transplant patients, because in some units, you know that it has been a little bit restricted due to comorbidities, etc., etc. And with this, I can stop for the sake of time and take your questions. Thank you very much.
Okay, thank you very much. Thank you for the nice words of introduction, and it's a great pleasure to be here. Although I would have preferred to be directly in your country, which is so wonderful, but we have the COVID, so we have to be cautious. I will try to define with you the immunological risk in kidney transplantation, because that's something that is probably more and more interesting. I will check only, and we speak only about the presence of DSA. The presence of DSA leads to the prevention of antibody-mediated rejections, and there is also a T-cell monitoring, but this will prevent the occurrence of TCMR, and I will focus mostly on DSA and not on T-cell monitoring. How to detect anti-HLA antibody? That's an important question. There must be an equilibrium between the detection in the serum of patients, no longer with microlymphotoxicity or flow cytometry, but mostly on Luminex or Immucor. And this must be an equilibrium with the definition of HLA in both donors and control. If you have ill-defined donors or ill-defined recipients, it's not very useful to have a detection of DSAs because you cannot work with that. So the definition of HLA must be very good in order to detect the the DSA in the serum of recipients. Just to remind, there are cell basis assays. We still use flow cytometry a little bit, although the place of flow cytometry is not that well defined in the literature. And most of us are working now with the Luminex in order to define a single antigen assay with a very high level of precision. So in the definition, if you get a given future kidney transplant recipients, if there is the presence of DSA before or at the time of transplantation, the patient is sensitized. And the rationale for that is that the presence of these DSA at time of transplantation has been strongly associated with an increased incidence of antibody-mediated rejection, but also more DGF, worse patient's graft survival, and worse renal function. So this is the meta-analysis showing that the presence of pre-existing DSA before transplantation and at time of transplantation increases the risk of acute antibody-mediated rejection and the risk of graft failure. But if the patient also developed after transplantation de novo DSA, you see also that this is the red curve. The consequence of the presence of this de novo DSA is worse than when the patient will not develop de novo DSA. That's the blue line. So obviously DSAs before or at time of transplantation or after are something that is deleterious. Why was it discovered only, I would say, between 15 years ago? Because indeed, some of us have transplanted patients with DSA that were present, but they were hidden because the method we had at that time were not enough sensitive to make a fair detection. There is another possibility when you know that you want the DSA, you can accept the DSA, and you know that from one HLA lab to another, the threshold is not always the same, so this might be complicated. Or you can transplant patient knowing that they have DSA and desensitize the patients. This gives also acceptable results, but it's longer. And just to remind you something simple, when you look at your patients, and I'm sure you have the same problem, this is our waiting list. You see that 60% of our patients have anti-HLA antibodies. And for example, when they are non-immunized, less than 5% of PRA, they are transplanted after 2 years and 8 months. While if they are highly immunized or just normally immunized, you see that when they are highly immunized, they spend 6.2 years in dialysis before they are transplanted. And this represents about a fourth of our all patients. So really we have to do something in order to transplant these patients that are very difficult to transplant. And there is a very good article that was published 2 years ago from Tambour. And this paper is describing the STAR group, which is a group of HLA people and clinicians, and they edicted rules in order to homogenize what we have to do before or after transplantation. What do we have to do with HLA typing? It has to be the most comprehensive as possible, and all loci have to be defined in order to define the specificity of DSA. So they should be performed with molecular method, and that is very simple and very clear. The best method to type the patients have to be used if possible. With regard to antibody, HLA antibody assessment, again, they have to be performed using solid phase assays. All the method must be used in order to remove the inhibition. We know that the best method is probably the dilution, but that's not always possible because it's very expensive. And we have to avoid the epitope sharing phenomenon in order to have true results. A word of terminology which is well described in this paper. The mean fluorescence intensity that we are using to define our DSA is different from a titer. It's not a titer because it's a semi-quantitative method. When a patient has 0 PRA, it doesn't mean that he is immunological naive, because some pregnancy are not studied afterwards with regard to DSA. These are the main terminology that we have to care of in our patients. What about the threshold of MFI to define if the patient has or not DSA? It's a very difficult question, because we are all using the DSA and define them with MFI, and we all say that we shouldn't do that, but at least in most countries we do that. And the best threshold that have been defined in the United States by Carol Reed was the 1,000 to 1,500. This is probably the best threshold. And also, when you look at the evolution, the course of DSA after transplantation, differences less than 25% probably must not be considered clinically meaningful. Historically, so the patients were defined with using PRA, and the patients with anti-HLA antibody reactive against the panel of normal individual was the definition of this PRA. But PRA must also be misleading, because it depends on the composition of the panel, and it depends also on the threshold of detection. So now we're using no longer this panel PRA, we're using calculated or virtual PRA. What we used to define sensitized patients were also patients that receive a second or more than second kidney transplantation, patients with the first graft loss from rejection, which is not always easy to define, multiparous women, multi-transfused recipients, patients with historical positive DSA or cross-match, and all in this situation where DSA may have been missed. So this is important, but nowadays, currently, we are using to define a patient with a low molecular immunological risk, patient without any DSA against their donor, at either before or at time of transplantation. Immunized recipients without DSA are also patients with a low immunological risk, and patients with an HLA identical or an identical twin are also, of course, also low immunological risk patients. There are also more complex definitions about memory responses. You know that when you have been immunized, we have also B memory cells that will come back very soon if after transplantation. So there are a new classification of the risk. We have the latent potential of an alloimmune memory. This is patients who have a sensitized event in their past history. We have active potential. These are donor-specific antibodies present at time, of course, very risky. And the alloimmune memory response are patients that will develop antibody after transplantation. That's about the equivalent of de novo DSA. So to evaluate the potential of a given patient for alloimmune memory, we have to look, of course, for HLA sensitized events, pregnancies, transfusions, previous transplant, implants, but also some inflammatory events that may boost this alloimmune memory, like major surgeries, major infections, or most likely recent vaccination. So only patients with HLA sensitized event may be considered as immunological low risk. You see that this definition is even more stronger than the previous one. So these are patients without DSA, but also without anti-HLA sensitizing event, which represent probably a small number of our patients. So to summarize the classification, you see the risk is the higher when the CDC cross-match is positive, but very few teams are doing this kind of transplantation. When you have DSA positive with the cross-match, it gives another indication. It's probably more deleterious than when you have DSA positive with a single bead antigen, but when CDC cross-match and flow cross-match are negative. And then you have also the patients with a history of sensitization, even though they do not have antibodies, pregnancy, prior transplant, and CPRA without unknown repeat mismatches. And also when you have the HLA identicant, the risk is very small, if any. So this is the risk stratification of donor-specific antibodies. But there is another stratification. This represents the patients who have been transplanted in our group with DSA at time of transplantation. And you see that this is peak or D0, 3 months and 1 year. And you see, for example, that in this second column, you have a red square patient with a very high level of DSA at 3 months, and just underneath the normal square, you see a patient with about the same MFI, but this patient will not develop chronic antibody-mediated rejection, while the first one with the same MFI will develop chronic antibody-mediated rejection. So we obviously need, for a better stratification, to define the patients that are at risk for graft loss. And we know that there is some kind of relationship between the risk of AMR and the level of MFI, but we don't know exactly which are the limits of the thresholds. We know from this already old paper that when you increase the level of DSA, you come from no rejection to C4D deposition to moderate rejection or to severe rejection. So there is a link between the level of DSA and the clinical events. But if there are thresholds, there might be one. This is coming from Paris. You see that when you use 3,000 as a threshold, you increase the risk of losing the kidneys. This is the blue and red line. While if the level of a DSA is lower than 3,000, the risk still exists, but it's less important. And this 3,000 MFI threshold has been also found in Germany. You see both in living-related and in deceased donation, you increase the risk when you have antibodies less than 3,000 or more than 3,000. So it's something that is not only present in Paris, but also in Berlin. Another way of stratify the risk is to use the possibility of the DSA to fix C1q. And this is the paper we published some years ago. When you compare in this slide the patients with no DSA after transplantation, that's the black line, or patients with DSA, that's the green line, you see obviously a difference between the results in these two curves. But we know that that's something that everybody knows. But if you split the green curve into two curves according to the DSA fixing or not the C1q, you see that when these DSAs are fixing C1q, the results, that's the red line, are very bad, while if the C1q is not, they are not fixing C1q, the results is acceptable. That's the blue curve. So we are not the only one to have done this work, and this is we perform a meta-analysis to show that each time complement is involved, either the C1q, but also the IgG3 serotype of IgG, the presence of T3D, the C4D. You see that all of these methods implementing or using the fixation of complement give bad results compared with those without. So we have to take this information into account. So as the conclusion, I will remind that the role of DSA is very important to stratify the risk either before, at time of transplantation, or after transplantation. The treatment should be ideally adapted according to the risk, but again, this is something that is quite new, and we don't know how exactly to adapt the treatment, but probably in the next few years we will be able to give a treatment that is adapted to the immunological risk, or at least more precise risk. And the help of HLA Lab is crucial because everything is becoming more and more complex. So thank you very much for your kind attention.
Thank you so much, Professor Pasquale and Professor Legendre, for the presentations. And we have from the audience 2 questions. I would like to address these questions, please. The first question is, why not to live on dialysis rather than transplantation? And the question states that a patient bought dialysis machine in his home. The second question is about what about induction TRT in this COVID era? What type of induction do you recommend? So please, Professor Legendre and Professor Pasquale, if you would like to comment on the 2 questions. Thank you.
Okay, thank you for the questions. I think that the first one is quite easy to me. One of my points in the talk was that we need to extend the access to transplantation, which is by no means really much better than dialysis for the general patient. I am not saying that the given patient that goes bad and has a lot of complications can die if you put a transplant on him or on her, but this is not the usual case. And the survival in the patient with a similar comorbidities, if it is transplantable in terms of it tolerates the surgical intervention and the heavy immunosuppression, is much better in terms of survival, in terms of quality of life, and in terms of the expectations that you have for the life in this patient. So I have no doubts. Kidney transplantation as of 2020 is much more convenient for your patient than dialysis, even if dialysis is at home, because with dialysis you only can have perhaps 50% of the kidney functions. You need a kidney to have full kidney function. And this is my view. In terms of induction, my opinion is that you have to restrict a little bit thymoglobulin in this era, and we try to avoid it other than the highly sensitized patients that of course you need it for avoiding heavy rejections. But we have decreased the dose and the number of patients that we do with thymoglobulin during the last 5 months. We prefer Simulate in general in this situation. Christophe, do you have an opinion on that?
No, I share regarding the second question. I think when you have a very high immunological risk, it's logical to use Thymo. Otherwise, it's probably enough to use anti-CD25. And if the patient is at a very low risk of developing rejection, like the one without any sensitized effect, probably it's even possible not to use any induction.
Yeah.
Was a little bit, sorry, my connection was a little bit not connected. I have a question for Professor Pasquale. Regarding the induction of for transplantation in the COVID era, what is the best induction to be used? And also, we know that you are the main editor of the Transform trial. So do you think that it is wise in this era to avoid using MPA altogether in our transplantations?
In relationship with the first question, you were not connected. I answered that and said that in this era, in these pandemics that we are installed now, I think that thymoglobulin should be restricted a little bit and use it only in heavily immune sensitized patients. And even as Christophe Legendre has underlined, even if you have a very low immunological risk with the first transplantation, very low risk, even you don't need any induction. Only with the drugs are enough. And in regards with Transform and the possibility of TAC everolimus, you know that my point is that if you don't have morbid obesity or a primary FSGS as underlying kidney disease or some very, very particular contraindications, I like more TAC everolimus. And in this era of COVID, I cannot say that everolimus is superior to MMF, but what you and me do with a patient with a viral infection, any viral infection, cytomegalovirus, BK virus, etc., you promptly decrease or even withdraw MMF. So why to use it in a scenario of a lot of viral infections? I try to avoid it, but we still use them in high immunological risk patients and patients with contraindication for mTOR inhibitors since day one.
A question for Professor Christophe Legendre. We know that you wrote more than 530 peer reviews, and you are editor or associate editor in many international journals. And you are aware of the debate between the donor-specific antibody, if they are just bystanders in the antibody-mediated rejection or etiological factors. There was a big debate in the last American Transplant Congress. So what is your opinion? Are there the main cause of antibody-mediated rejection, or they are just bystanders in the fire?
That's a good question, a good and not simple question. You have the cases that are very simple. The patients develop de novo DSA. He is developing also antibody-mediated rejection on histology. Is that simple, and they respond to the treatment. But sometimes we all have patients with very high level of DSA, and they are performing very well. That's why we're using the C1q fixing DSA. What we do in this instance, we do a biopsy. If the biopsy is quiet, and if there is nothing, I mean, you can live with, the patient can live with his DSA. But about in 50% of cases, we found chronic active antibody-mediated rejection that should be treated, but so far there are no very efficient treatment, or maybe tocilizumab is maybe one of the best, but it's still not very active. So we don't have a good treatment for chronic active antibody-mediated rejection. And the third thing that we have patients with antibody without antibody-mediated patients with antibody-mediated rejection and no DSA. And probably these are due to non-HLA DSA, but this is more and more frequent, and we don't know how to explain these cases because we don't have the specificity of the potential donor-specific antibody. So the situation is becoming more and more complex instead of becoming more and more simple.
A last question for Professor Rolio-Pascual. One pessimistic nephrologist is asking, why not to stop transplantation whatsoever in this still era of COVID and go the patient continuing to live on dialysis until we finish all the second and third waves of COVID?
No, this is, I can tell you that this is not a madness. So we closed the program for 2 months in our hospital. It was impossible to have safe transplantation at the moment. But after the first wave, the first tsunami, we got a good pathway to put our patients safely on the OR and with a good team and some ICU place during the first hours after transplantation, etc. So we have been able to reopen the program quite safely because we have learned a lot suffering so much. So I think that you should not cancel all the programs, and if you got a good pathway to put your kidneys safely in your patients, please maintain that, because your patients will be very, very well treated with this. The patients cannot wait for a year, if you have a good donor. And we need to maintain and to keep the programs active, but still you need to have strict pathways, clean pathways to separate a lot the COVID from the non-COVID in your hospital, etc. And if you get it, I think that the risk is worthy to take.
Thank you very much. It was a very enlightening discussion. And thank you, Professor Julio Pascual and Professor Legendre. And I think we will proceed in our talk. We will get Professor Tariq El-Baz soon.
If I can ask a question, please, Professor Hani.
Please, go on.
Pascual. Hi. You gave us a very nice talk, Professor Pascual, and you mentioned some interesting points. First, that tacrolimus seems to be quite helpful in preventing the replication of the COVID-19. So it seems. Okay, but just one point that I'm wondering about is that study you showed, or the statement you mentioned regarding the ramipril, that it is not showing any benefits in the post-transplant period, while of course this is a recommended antihypertensive drug with well-proven benefits when the patient was in a state of CKD, and we have so many trials to say that. How is it when the transplanted kidney is already something like a CKD at a very early stage? How is it? How could it be that the ACE inhibitor is not giving the same benefits?
Yeah, we have a lot of trials. I have said it in my talk with diabetic and non-diabetic kidney disease, where the ACE inhibitors and even the ARBs are really helpful for retarding progression of CKD, etc. But we don't have still in transplantation, we have few trials, and the trials that are available are not confirming this very important effect. I think that we have difficulties in the design, the samples are low, perhaps the proteinuria is heavy in these cases, I don't know. But you have definitely good antiproteinuric effects, but you are not able to retard progression of CKD in these transplant patients. And this is the data that we have to date. So I hope that in a given moment we could be able to see with SGLT inhibition, in addition to ACE inhibitors, etc., with the nice results that we have now for the CKD patients, non-transplanted patients. But in the kidney transplant patients, we had in Spain a large trial with losartan 10 years ago, which completely failed to show any beneficial effect. I don't know, the kidney transplant is behaving different than the native kidneys in this sense.
Could it be that these particular patients are naturally progressing due to chronic allograft dysfunction? Could this be the cause?
Yeah, of course, could be. Perhaps the underlying damage is different, and the ACE inhibition is not able to cover this in transplant patients with these immunological effects, etc. I don't know.
Thank you.
A last question for Professor Christophe Legendre. Is there if the CMV level is not detected by PCR, would it still be one of the underlying factor in ABMR or not? Underlying causes in ABMR, if it is not detected by CMV PCR?
No, I don't think so. I'm not sure I understand perfectly your question.
One of the audience is asking the role of cytomegalovirus in ABMR if it is not detected by blood testing. Is there any role for it, or if it is not detected, so it is not?
I'm trying to search for it, but I don't think it's there are a relationship between CMV and renal function, but that's not very clear, and I don't think that we see antibody-mediated rejection due to CMV. It creates sometimes microangiopathy. It's clear in some patients, but being responsible directly for antibody-mediated rejection, I don't think so. I haven't seen that in the recent literature.
Thank you very, very much. And we should move now for the next speaker, Professor Tarek Elbaz. Professor Tarek Elbaz. I think we will go for a stop, then we will start sharing the. We are online. It gives me a great honor and pleasure to present my dear brother and colleague, Professor Tarek Elbaz, Emeritus Professor of Internal Medicine and Nephrology at Al-Azhar University and President of the Arab Society of Nephrology and Transplantation. And he is the chair of the ESNT Clinical Nephrology and CKD chapter. He will be speaking about intervention for preventing bone disease after kidney transplantation.
Thank you very much, Professor Hani Hafiz. It's a wonderful opportunity to be in such a good meeting. I appreciate so much a kind invitation by Sandoz, and I hope what I have to say will be interesting in the same context of what has been said before. We all understand that protecting the kidneys that we have transplanted is something of prime importance, is so precious, and a lot of post-transplant challenges do exist, as you can see depicted in this slide. Infections, cardiovascular morbidity, some of these may really be easier than others, and by others is what I'm going to talk about today, that the bony changes, osteoporosis, hyperparathyroidism, and the associated fractures really carry a lot of challenge to our patients. We are all quite aware of the kidney-bone vascular axis, and there's a good realization now that the cardiovascular part related to CKD-MBD is really serious, and a lot of literature is now ongoing. And I look to things as if it is the warm-up before the sonata. All this literature and all these experimentation will lead us very soon to a much better understanding of CKD-MBD. That a few years back, Dr. Mario Cozzolino was head of the working group of ERA-EDTA for CKD-MBD, thought that maybe he can fit in CKD-MBD into a syndrome, but unfortunately this was not possible. But maybe refinement through looking at nutrition, inflammation, and other still endocrinal functions of bone will help those interested to try to define CKD-MBD as a real syndrome. Bone diseases after transplantation carry a lot of morbidities due to hospitalization, healthcare costs, all related to fractures and so forth, and definitely fractures have been plotted against mortality for transplanted patients. The pathophysiology, as we all understand, is quite complex and even much more than what was when the patient was in the CKD period and even during dialysis. There are other factors that are adding to the complexity of the pathophysiology. The pre-existing situation related to osteodystrophy, and now the addition of the immunosuppression and what it is doing, all of these things together are making things very different and very difficult to interpret as well. Regarding the pathophysiology, of course, there is a better understanding now. We have a better map of the prevalence and a better understanding of the pathophysiology, yet not yet that complete. There is still a problem related to diagnostics and definitely therapeutics. The experimentation that has been done or the publications so far are not all that consistent in order to draw guidelines. These are some of the bony changes that are happening after kidney transplantation, and you can see that persistence of secondary hyperparathyroidism has a 50% incidence. Osteoporosis as well is a major problem. And now this is very interesting, the hypophosphatemia. We have been always worried about hyperphosphatemia in our patients. I will come to this point later on. And now we may be facing hypophosphatemia, particularly in the immediate post-transplant period. This diagram depicts what is happening related to demineralization of bone. Of course, glucocorticoids are terrible. They are increasing the osteoclastic resorption of bone. Also, phosphatonin, if I better say FGF23, leading to hypophosphatemia. We understand that FGF23 reaches maybe 1,000-fold the normal level when the patient is on dialysis, and then it starts to fall after transplantation. In the initial period, the first 3 to 4 months, it's still high, leading now to hypophosphatemia because the patient would have normal renal tubules, and this hypophosphatemia would definitely lead to deficient bone formation and could also decrease the osteoclastogenesis and increase the apoptosis. All are factors leading to defective mineralization of the bone. What is happening as fractures? Mainly the fractures may be affecting either the lumbar spine in particular and the hip, very common sites for these fractures. And they try to use the fracture risk assessment tool in order to predict which patient actually is liable to fracture, but it doesn't apply all that well in our patients due to the multifactorial nature of the disease, and the variables are plenty. It is not just related to osteoporosis like in the general population. And over the first 3 years of transplantation, a patient may get a hip fracture risk as high as 34% compared to patients on dialysis, and a hip and a spine fracture risk also may reach even 23-fold higher than in the general population. So we understand that these patients are so liable to acquiring a fracture, and the osteoporosis risk for these is not that different from the general population, as you can see in this table. Always age is an important factor, the poor nutrition, smoking, alcohol abuse, and so forth. Also, the risks for fractures may be related to a pre-existing history of fracture, or already the occurrence or the presence of a lumbar osteoporosis or a renal osteodystrophy. And I think not all patients would have some degree of these bony changes, whether osteodystrophy or mixed forms. This is something very common in patients, particularly those who have been on dialysis for a few years. If a patient has a tendency to fall, this is adding to the risk of the occurrence of a fracture. And as I heard from Professor Pascual, a lot of patients in Spain are elderly, above 80, and here this category of patients may have sort of partial instability or decreased visual acuity. All of these risk factors together may lead to falls. With brittle bones, it's easy to get them broken and fractured. Now, moving on to the last part of my talk, which is therapeutic interventions. And again, we have insufficient sensitivity of imaging and definitely bone biomarkers. We cannot go and assess everything that we know now, the sclerostin and so forth, and all these advanced biomarkers for all patients. And again, a bone biopsy, which is a gold standard of diagnosis, definitely is not widely there. and if it's there, the expertise is not there. Well, at least in my country, we don't have good expertise in this part. So we are left with the imaging. And the diagnostic imaging that we do have is the dual energy X-ray absorptiometry, the DEXA, and lately the high resolution peripheral quantitative computed tomography. For DEXA, it is not very sensitive actually in our patients because it reflects osteoporosis when our patients do not only have osteoporosis, have other lesions, yet it is still of help somehow when you apply it to patients, and it doesn't take so much time, the test itself. But it is unable to determine a very important point, is this patient running a high turnover or a low turnover condition. Yet this diagnostic imaging, relatively new technique, is much better. Three-dimensional photomicrographs are available. You can really tell and differentiate between the cortical bone and the trabecular bone, and you can really assess the volume. Yet it is still a very expensive tool, and lately it is just used for research. But here it is. Maybe in the future it would be widely available. When you assess patients' laboratory, you would be using the same biomarkers that you are using to assess patients for CKD-MBD, whether calcium, phosphorus, intact PTH, and vitamin D, but there's a different timeline for assessing these things. Particularly in the beginning, you would like to assess the phosphorus, as I just mentioned, with the liability of having hypophosphatemia. Also, serum calcium is quite variable. You may get patients having hypercalcemia, particularly those that you are maintaining still on calcium or active or native vitamin D for vitamin D deficiency or existing secondary hyperparathyroidism. Now, an important point related to what's happening is the immunosuppression, and on top of the list, we all understand that glucocorticoids are very deleterious, or I mean, they damage the bone so much. They promote osteoclastogenesis, impair the osteoblastogenesis, and definitely increase the renal calcium excretion and more. So glucocorticoids are really serious in this regard, and they lead both to osteoporosis and osteonecrosis, which may affect, not uncommonly, the neck of the femur. And a very important large observation study that studied 77,000 patients that were transplanted showed us really that early steroid withdrawal protocols, we are not doing this yet in Egypt, but steroid withdrawal protocols were really associated with a 31% reduction in fracture risk. This is quite logical, of course, but steroid withdrawal is something that really you have to gain quite an experience in. Now, the CNIs also have been linked to osteoporosis, but this may be debatable because CNIs are causing stimulation of osteoclasts and osteoblast activity at the same time, but the trend is towards stimulation of osteoclastic activity. Hence, they could share in the occurrence of osteoporosis in some patients. While the sirolimus and everolimus seem to be more beneficial, improving the functions of the osteoblast and decreasing even the osteoclast bone resorption. So this is in addition to the benefits of sirolimus and everolimus that we just have heard. A lot of publications are coming now in the literature related to interventions, yet there is no really consistent, or let me say, grading for what is published because there's no proper guidelines. Still, the map is deficient and we do not have guidelines, and what is done now as an intervention is extrapolated from the results of treatment of patients on dialysis or CKD, it's not always the same condition in transplantation as some trials have shown us. The outlines of treatment would be what I have put in this table: the nutritional vitamin D or the VDRAs, the calcium mimetics, the teriparatide, the anti-resorptive agents such as bisphosphonates and denosumab. I have been talking about phosphorus a few minutes ago, and I just have to enlighten you with that it is important to check the serum phosphorus in patients, and particularly in the first month, and don't try to work the patient up to normal levels, because this may be dangerous. It may really aggravate the presence, the already present secondary hyperparathyroidism. So you just keep it in the level of 2 milligrams or a little bit higher. This would be acceptable when correcting hypophosphatemia, which is resulting from the pre-existing high levels of FGF23. You would like to use calcium and cholecalciferol in some of your patients. Well, this is good, but again, I have to caution you against checking the serum calcium frequently and correcting it if there is a state of associated hypoalbuminemia, for fear of hypercalcemia in our patients. Now, cinacalcet has been very beneficial to treat secondary hyperparathyroidism, and it withstood the test of time related to safety for our patients with CKD and even on dialysis. We've been using it since a very long time, and it does really help in regression of the parathyroid hyperplasia. Yet, also, we have to realize that cinacalcet may affect the serum levels of tacrolimus, and tacrolimus is a standard of care, as Professor Pasquale just mentioned. So we have to be on the watch for the levels when we are using cinacalcet in a particular patient with secondary hyperparathyroidism. Teriparatide has been shown to be a very effective treatment for those patients with adynamic bone disease, which is not uncommon at all in our patient. And this study, among others, did show that there is a marked improvement in the bone mineral density at the lumbar spine that is increasing by time. So it seems to be of benefit in these patients. And it is very interesting that teriparatide actually could be helpful in those patients that we are meeting frequently, those patients who do have severe osteoporosis and evidence of a dynamic bone disease. So here you have something that could be of help for this particular group of patients. It is, of course, an expensive drug, and there is not enough supporting data from randomized controlled trials, particularly in patients receiving a renal transplant. And this is another problem. So we cannot really strongly say about this particular drug, it is fit for all patients. The anti-resorptive agent, the bisphosphonates, some publications show that it could be of help in patients on dialysis with CKD, but unfortunately, we may have serious problems from this group of drugs with reduced GFR. So we have to be really cautious when using bisphosphonates to treat bone loss that may be present with kidney transplantation. This is so much for the bisphosphonates. And although this recent, more or less recent publication did show that current immunosuppressive regimens do not contribute to post-transplant central skeleton trabecular bone loss, and they mentioned that this particular zoledronate does not induce dynamic bone disease. This is just one publication favoring the use of this particular drug, but really I cannot recommend its use. The most recent comer and the last drug I'm talking about today is the denosumab that binds to rancl, stopping the activity of the osteoclasts. Of course, this injectable monoclonal antibody has shown very good results in the general population treating osteoporosis. And of course, the frequency of injection is not doesn't bother so much the patient. Yet again, clinical studies indicating the long-term effects with denosumab are needed in this particular group of patients, those with renal transplant. So in conclusions, ladies and gentlemen, the pre-transplant CKD-MVD is quite complex. The physiology is still not that clear. Pathophysiology, I mean, a lot of secrets are revealing nowadays. We have to always consider the immunosuppression, particularly the glucocorticoids. The faster we can go down with the immunosuppression, the better. And definitely the results are much better than years back or decades back when transplant physicians were using much higher doses of steroids. Still, we have a limitation regarding the imaging and biomarkers. And again, I'd like to remind you about caution when using biphosphonates and denosumab. Although it is quite effective, yet we still need some long-term trials in order to really conclude if it is beneficial or not. I thank you all for your kind intention. And before I go, I have to convey to you the condolences of the board of the Arab Society to this great friend of mine, Professor Hussein Shaisha. Again, I regard him as a phenomenon. He was really a phenomenon, so much dedicated to medical education, not only in Egypt, but all Arab world. Everyone is going to miss Hussein. May God bless his soul, and thank you all so much.
Thank you very much, Professor Tarek. Very illustrative talk. We will go directly to the next talk because of shortage of time, and then we will have the discussion afterward. Now we will go for the United Kingdom, Professor Frank Dorr, consultant, transplant surgeon, and the head of the transplantation of the Imperial College Healthcare NHS Trust in the UK, and he will be giving an important subject of preemptive transplantation. Professor Frank Dorr, please.
Thank you so very much. I haven't been able to test my microphone yet, so is it working? Good evening. Thank you so much for the kind introduction and the very kind invitation. I'm really thrilled to speak about this topic because it is very close to my heart. I may warn you because it might be slightly provocative, so stay with me and hopefully you enjoy it. So the title is, of course, we're talking about preemptive transplantation, and I really would like to say it's time to change the default. Some disclosures, as always. I think, this is the key slide of every presentation and also answers one of the questions from the audience. We really have to work hard to transplant more people because staying on dialysis is associated with a huge mortality risk. And this was alluded to by previous speakers. I'm really passionate about this. And people don't realize often that many cancers these days have a better survival rate than patients on dialysis have. And of course, transplantation, as Julio also said, is not for everyone always the best option. But for most of the people, it's still much better than staying on dialysis. If you look at the European problem, so to speak, and I am from Holland originally, so I am still eligible talking about Europe, even though I work in the UK. Lots of patients on dialysis, lots of people waiting for a transplant, but you see there is already almost half of people on dialysis are not even on the waiting list. And the numbers of transplants, despite all our efforts in most countries, are quite disappointing. resulting in a long waiting time for people, resulting in lots of people dying per year on dialysis. And this is key. We don't know in every country how many patients are not even on the wait list or are being removed from the wait list every year. So there is a clear need for some better registry data. So how do we get more donors? Because this seems to be the biggest problem. We have expanded criteria for deceased donors. We have included lots of smart translational approaches using machine conditioning, ischemic reconditioning, use of stem cells, and all kinds of other reconditioning strategies to make untransplantable organs perhaps a bit better transplantable. Lots of countries are currently changing or have recently changed the legal system from an opt-in system to an opt-out system, hopefully thereby, I think, largely changing the culture toward organ donation, that this should be the default rather than a luxury. And lots of countries in Europe have really actively promoted or raised awareness about the options that live donation brings. And specifically for preemptive transplantation, this is key. Live donation offers several other options, of course, like kidney pad exchange, having altruistic donors initiating change of transplants, and we can do ABO incompatible and even HLA incompatible transplants, as Christophe also mentioned, with desensitization strategies. But that might also require legal changes, and I would really highly recommend people reading this book on living donation and several legal regulations in Europe on this topic. And I think there's still a lot to gain. But this is, of course, not the topic of this talk. Some examples of legal legalities, basically, in Europe are given here if people are interested. So I already mentioned how to increase the donor pool, and it feels sometimes we have to go to extremes to make living organ donation possible and even to disincentivize living kidney donation. And I think it's really important for preemptive transplantation, so that's why I emphasize it so much. The advantages of living kidney donation for recipients, but also for donors to a certain extent, is, of course, the elective nature. We can plan things. We can see people deteriorating in their chronic kidney disease, and we might be able to plan working up a living donor and plan a living donor transplantation preemptively. So why not? That's what we have to ask ourselves constantly. The advantages for the recipients are numerous. I mean, we can prevent dialysis and the associated morbidity and even mortality, as I've shown from a large prospective Dutch study with thousands of patients included. We also have the option for alternative programs. I already mentioned that too. Also, the living kidney donors obviously are well-selected, healthy human beings, and they should have perfect kidneys almost, even if we accept extended criteria living donors a lot these days. The cold ischemia time is short. Kidneys normally don't travel, only in kidney pad exchanges in some countries. But for example, in the Netherlands, the donor travels to the recipient hospital. So it's still a short cold ischemia time, resulting in a superior graft function. Living donor kidneys usually go nearly twice as long in terms of graft survival compared to deceased donation kidneys. But obviously, this is never the case for every individual, as highlighted by previous speakers. Living donation also makes impossible transplants possible because we can plan for it, we can pre-treat. And only today we had a young girl that got a kidney from a friend, from a living donor, and has a high risk for recurrence of her FSGS. And because of her pre-treatment options and the way that we can treat her post-transplantation, we can do impossible transplants. And I will show you an example next of another impossible transplant. Lots of people also don't realize how much economic advantages for healthcare systems a kidney transplant would have, and could save, up to £700,000 per 10 years compared to being on dialysis per patient. So this is one of the examples of an impossible transplant, and then in basically a preemptive transplant as well. This young chap in the middle got a 7th kidney transplant in my old center in Rotterdam in the Netherlands. He actually approached the Guinness Book of World Records and seems to be the guy who holds the record on the most kidney transplants ever. Nothing of credit, of course, for us, but a very special guy. He was 33 when he had a kidney from an HLA-000 mismatched kidney from an estranged sister, having had 6 transplants that failed for technical reasons and antibody-mediated rejections, highly sensitized, and due to desensitization strategies was able to get this. Surgically and immunologically highly challenging. So this is the picture in Europe. This is the activity of living donor kidney transplantation, and this is from the Council of Europe newsletter from last year, where you can see that in Europe the activity really varies a lot, and unfortunately Egypt just fallen off the map. I'm sorry, but I couldn't put it back on. And you see that there is a huge variety in living donor kidney transplantation, and we can easily translate that into preemptive transplantation because that almost reflects the same figures. The question is really why that is. And obviously there's countries with high numbers of DBD donors and barely have the need, so to speak, in their view, to do more living donor kidney transplantation. I don't think this is entirely true, but this is not the scope of this talk. Of course, we have to bear in mind that living kidney donation is a very serious business. This morning, I did a living kidney donor in a 24-year-old girl, and you have to make sure that there is no mortality and there is no morbidity. Well, there is no such operation that actually can provide this. We should not harm the kidney. We should make sure there is no long-term risk, ideally. And there should be a good quality of life and quick recovery after the donation procedure. But it's still a real operation. It's a healthy person that doesn't need it and will not have any therapeutic benefit of this donation. Of course, there will be many psychosocial benefits and all the rest of it. And often when it comes down to partners or friends or family members, it's great that you see that this person will have a better life and a better life prospect and quality of life in general, and you might benefit from that as well. However, the mortality is not zero, and we normally quote a 1 in 3,000 mortality. We don't really know what this figure is because there is an underreport. It's underreported in the literature, of course, what donor mortality encompasses. In the literature, when you do a systematic review that we published a couple of years ago, we see that the morbidity is about, apologies, 2.3% intraoperatively, so not zero. And also post-operatively, complications are going up to 7.3%, so not zero again. However, most of the complications are mild and self-limiting and don't require any re-intervention or re-operation, and luckily. And of course, there's lots of literature on long-term risk in terms of attributable risk and relative risk of live donation. Again, not the topic of this talk, but should not be neglected. So some facts about kidney disease, and of course you know all that end-stage kidney disease is growing in the world, growing number of patients that we have to treat, and also the patients with end-stage kidney disease, the number of elderly people, so 65 years and older, requiring renal replacement therapy as well. So it's a difficult thing and increasing. Kidney transplantation, obviously, the demand is rising, especially when the numbers of the need are increasing and we don't have enough organs. I already mentioned that. And in the UK, for example, the living donor transplants are about 40% of all transplants, and deceased donor transplants about 60%, which is clear from this picture. The picture really hasn't changed, and there's about 1,000 of living donors per year in the UK, and the increasing numbers of DBD and DCD donors are actually good news. And this is part of the new strategy that was developed by NHS Blood and Transplant. See? So facts about preemptive transplantation. Only 22% of all kidney transplantations in the UK are preemptive. And I think we have to do a lot of work to increase that. the number of living, so it's 36% of all living donor kidney transplants and only 16% of deceased donor kidney transplantation. And just to summarize, there is a huge variety of preemptive transplantation in the various units in the UK, which is about 23 to 24 transplant units. In the US, and I barely dare to pronounce it these days, this exciting day today with US elections, but preemptive transplantation is even less than in the UK. It's about 17%, with the highest percentages again from living donor transplants. In the Netherlands, it's increasing, and it definitely shows a trend towards about 30%, which is quite good actually. A country with high numbers, one of the highest in the world actually of living donor transplantation per million inhabitants. So good news, and actually shows that it can happen. So if you look at kidney transplantation activity of all donor types in Europe, you see again the same variety is true as I showed you before for living donor transplants, with obviously Spain leading the way. Julio, thank you very much. UK and the Netherlands not doing very badly, still lots of room for improvement. And you see that where you live in Europe, and it's true for the rest of the world, determines your chance to get a transplant. So there's lots of inequity of access to transplantation, which is something that we really have to address. So deceased donors, again, high numbers and high percentages in Spain, and in France, much better than in the Netherlands and the UK and Denmark, and also, you see in Scandinavia, there's quite high percentages. And this almost seems to be the opposite for living donor kidney transplantation in Europe. And I've shown you this picture already, where I think there's even more work to be done. So one of the big advantages I mentioned of living kidney donation is actually that it would really make preemptive transplantation possible. I always say this to patients, you really can get back control over your disease and over your life if you would have a live donor and you could prevent dialysis. But we're not doing greatly in terms of pathways, and I'll come back to that in a second. Of course, you've seen this picture today many times with blue and red colors, and we still have to wait for the final results. But this is a picture of the US in terms of preemptive transplantation and transplantation after dialysis of less than 1 year. You see, again, there's a huge variety in wherever you live determines your chance for getting a preemptive transplant. But there are areas where in the US, things are really much better in terms of preemptive transplantation compared to many European places. But again, there's inequity of access. So this is the picture of preemptive kidney transplantation in Europe, and lots of organizers are now very frantically looking at this empty slide and saying, I made a mistake. But actually, we don't really know. There is no European registry that looks into this. And despite all our efforts to do better, I think we really have to show a picture in Europe in the next couple of years with figures on preemptive transplantation. So 10-year graft survival absolutely is better with preemptive transplantation compared to a non-preemptive transplantation. Also, patient survival, graft survival, all much better. And there's many, many studies from all over the world, and some of them are nearly 20 years old and still true, showing the advantage of preemptive transplantation, even compared to a couple of months of dialysis, which is massive. This is, I think, a key study from Maya Krischer, 2002. It was already there. And what have we done about it? Showing that, no dialysis at all. This top mark here really has benefits over even a couple of months of dialysis, but incrementally so with incremental years of months of dialysis. This is a recent study. I think this, Christophe, is a nice example of a national database from France in this case, where the same sort of data are seen, that the survival probability without return to dialysis or retransplant is much better after preemptive transplantation Certainly, this difference is significant after 5 to 6 years compared to any time on dialysis. Very powerful data. I think one of the other, it looks very old, this slide, and I like to keep it old as well, because it shows that this message should have been around for so long, that overall death rate after preemptive transplantation compared to non-preemptive transplantation after any month of dialysis is much better after preemptive transplantation. So there's less risk for mortality, and this is largely due to the fact that cardiovascular comorbidities or cardiovascular complications of dialysis are way less after preemptive transplantation. Obviously, it's difficult to predict when we need to transplant, and also to show that diabetics versus non-diabetics obviously tend to deteriorate much more rapidly. And it's difficult to predict when a transplant would be beneficial. Obviously, there's lots of data that came out of that afterwards, but it is a key message and a key thing to consider for the discussion. In my previous center in Rotterdam, in the Netherlands, we reached 45% of preemptive transplantation, largely due to the fact that we had so many living donor kidney transplants. And one of the, I think at that time, before I left at least, we had 120 live donor kidney transplants a year, and the highest number we reached was 150 per year, and lots of them were preemptive. So it all is about philosophy and pathways and making sure things happen. And what happened to the kidney transplant waiting list, and again, this is not updated data, but it's still true, that because of the living donor preemptive transplants, we have been able to decrease the waiting list enormously. And actually, the number of transplants is higher than the number of patients on the waiting lists. So I think this is a clear message of success. Daniel Abramovich has, together with the Descartes Working Group, done a very nice paper a couple of years ago about preemptive transplantation, trying to summarize literature in a systematic way, and also to find an answer as to what the optimal time is for such a transplant. And they recommended, based on the literature level 1D, that we should all have living donor kidney transplantation, predominantly preemptively, that should be all stimulated. Preemptive transplantation should be organized in such a way that dialysis can be avoided. And again, level 1A evidence. And this should not be based on a fixed or predetermined GFR level, but rather should take into account clinical and biochemical parameters as well. So I think this is a very interesting paper for those who are interested. We did a systematic review and meta-analysis a couple of years ago, and we unfortunately haven't published it yet because we keep updating it. There are lots of beliefs about preemptive transplantation and, in my view, non-substantiated views as well. People think that you will have an increased rejection because of a lack of immunosuppressive effects of uremia. Other people even think that you might be less adherent or compliant due to the lack of experience of dialysis. And some people even advocate for like a time on dialysis as a sort of a testing period or punishment to see where it's all about, and then for you to take your immunosuppression. But actually, we do know that it avoids the complications of the comorbidities of the dialysis, and it avoids an unnecessary operation such as a fistula creation or PD, and it is extremely cost effective. So you know all these logistics. I'm going to, in terms of time, just going to run through this more quickly. We have screened lots and lots of papers, and lots of patients were actually included from all over the world, as I mentioned, thousands of patients included. And actually, the delayed graft function is significantly different in favor of preemptive transplantation. Makes sense. But acute rejection rates are also lots in favor of preemptive transplantation. Same is true for 5-year death of the patient and 5-year allograft survival of the kidney. So all in favor of preemptive transplantation. So we really have to change the default. We all learned in medical school that we have to start dialysis when kidney patients reach end-stage kidney disease. And then we waitlist them for deceased donor kidney transplantation. They wait several years and might get transplanted. And at the same time, we could consider, talking to them about live donor kidney transplantation after starting dialysis or after being waitlisted for deceased donor transplantation. In my view, all our work should really evolve around making sure preemptive transplantation with a live donor can be done first. If that doesn't happen and people crash land and they need dialysis, we can do a live donor kidney transplantation. I think it's a double kidney transplantation in this case here, after starting dialysis. And of course, preemptive waitlisting for deceased donor kidney transplantation should happen as much as possible. So the timing of preemptive transplantation remains a controversy by itself. And all the guidelines basically say shortly or a few months before we need to initiate dialysis, although we are not very good in predicting for every patient. So the earlier the better. And really, in my previous practice, that's more than 5 years ago now, we transplanted people with a live donor kidney transplant, for a live donor kidney transplantation less than GFR of 20, or when they had symptoms. I'm sure you all know this, but there's a quite interesting web-based kidney failure risk equation to see, how quickly deteriorates the kidney function in end-stage kidney patients in order to help us predicting when we should transplant them if they have a live donor. So good literature there. A few words about deceased donor transplantation. I can summarize that very quickly just to say that, of course, it is a different ballgame. We can preemptively list patients for deceased donor transplants, but in many cases, in many countries, they don't acquire lots of points while waiting because the system is not set for preemptive deceased donor transplantation. Of course, if you have enough kidneys on the shelves in your country, and a few countries might qualify for that, you might have a short waiting time in Norway or Spain or other countries, but there's not many countries that can guarantee a preemptive transplantation with a deceased donor. And it's less employed as well across the globe. But the outcomes for patient survival are still much better than for non-preemptive. The graft survival is much better than for non-preemptive. And also death-censored graft survival and all the other outcomes are in the same sort of favor. So to think there is robust clinical evidence in favor of preemptive transplantation, but we are not doing it. For living donors, why are there not more preemptive transplants? There's disparity and inequality of access to transplantation in general, also in living donor transplants in general, and even more so for preemptive live donor transplants. Live donor transplants has the advantage that it doesn't jeopardize other patients on the waiting list. There's no competition because they bring their own donor and you can transplant them whenever they want, and there's no ethical inequality. Timings and logistics have to be, of course, optimized, and we do need registry data in Europe and beyond on activity. For deceased donor transplantation preemptively, it is difficult because it is a scarce resource in most countries. So is it really fair to list more patients preemptively and then to compete with other people actually for the same kidney and they are waiting for a longer time? Of course, that particular kidney from the donor might do much better. And actually, you might justify that by saying every kidney should have the longest possible survival in every possible recipient. So therefore, preemptive transplantation is advocated for. But it is difficult. It's the individual versus the society. Again, there is lots of disparity and inequality. And we should perhaps consider that if you're preemptive as a deceased donor transplant recipient, we should only really have a standard criteria donor kidney or a good enough kidney and prevent disasters of having extended criteria DCD kidneys with primary non-function, of course, and potentially sensitizing those recipients. Lots of considerations. I really think it's time to change the default. And I mentioned already what that should look like in my view. Now, how to get there? Education, education, education. Not just our patients, but also our colleagues, our referring colleagues, our healthcare professionals, our healthcare management, politicians, and policymakers. all our pathways, that's something we can do with help of our healthcare system, should be changed towards preemptive transplantation, first with a living donor. We should disincentivize, therefore, living donor kidney transplantation, fully embrace all the options that living donation has to bring, remove financial incentives for dialysis. And this is the elephant in the room. There's still many hospitals and healthcare systems where dialysis gets paid more and reimbursed more than transplantation. And that's a tricky point, especially with management. And in the UK, certainly, you can earn more money as a hospital by putting a patient on dialysis first. And there's countries in Europe, actually, patients have to have a period of dialysis first before they're even considered for transplantation, which is, in my view, completely and utterly wrong. So let's work together and remove all these barriers towards preemptive transplantation and make preemptive kidney transplantation even a quality indicator of your kidney program. And I would love to hear your views. So thanks for the attention.
Thank you very, very much, Professor Frank Dorr. I think you convinced all the audience of the importance of preemptive transplantation. And for the sake of the time, we will go forward for the next remaining two important talks, and then we'll make the questions at the end. The next speaker will be Professor Tariq Fayyad. He will be giving, Professor Tariq Fayyad is Professor of Nephrology and Medicine at Cairo University, and he will be speaking about immunosuppression in kidney transplant, a very difficult subject, but he will make it easy.
Thank you, Dr. Hani, very much, but can they allow me to start my video because the host doesn't allow? Sorry for the delay. Thank you so much, Dr. Hani and Sandoz, particularly Mariam. And my task tonight is immunosuppression in kidney transplantation made easy. This is an old slide which shows our current success, the reduction in the incidence of acute rejection over time by the development of new immunosuppression agents and the increase in the one-year graft survival. And as you see, the one-year graft loss is decreasing, but on the other hand, from 1 to 3 years, from 3 to 5, and from 5 to 10 is still the same, is not changing. And this is an unmet need. The causes of graft death with function are cardiovascular diseases, infections, and malignancies, and this is probably complications of immunosuppression, and this is the second unmet need. We don't use drugs, we are using regimens, otherwise we will have enormous toxicities if we use only tacrolimus to prevent rejection. Our aim is to prevent T-cell activation and cellular proliferation in order to prevent rejection. And what are the factors influencing our selection of immunosuppressive protocols? Randomized controlled trials like Symphony, like Elite Symphony trial or the Transform trial, or the immunological risk. The highly sensitized patient is different than the low-risk patients, and the comorbidities, the obese patients should receive different immunos, and the diabetics and the elderly, etc. And here are the guidelines of 2009 regarding induction therapies. All patients should receive induction. The low risk should receive interleukin-2 receptor antagonists, and the high risk should receive thymoglobulin. And the induction agents are either non-depleting, the interleukin-2 antagonists, or depleting the polyclonal thymoglobulin or the monoclonal alemtuzumab, which is anti-CD52. And this is an important paper which compared between the ATG and basiliximab. You can see here the low incidence of acute rejection in the ATG group and the low incidence of antibody-mediated rejection in the ATG group. What about alemtuzumab? Here they compared alemtuzumab versus ATG in the high-risk patients. and the depleting alemtuzumab versus non-depleting basiliximab in the low-risk patient. And as you see regarding acute rejection, the difference is very little in the high-risk patients between alemtuzumab and the ATG, and the incidence of acute rejection is less in alemtuzumab versus basiliximab in the low risk. But regarding patient and graft survival, there is no difference. That's why it is recommended to use basiliximab in the low risk patient. And the question now is, do we still need induction therapy in the current era of strong conventional therapy? No large randomized trial has examined the effect of interleukin-2 receptor antagonists or ATG versus no induction in patients receiving current conventional treatment. When you give induction treatment, there is a reduction of the incidence of acute rejection by 1 to 4% and no impact on patient or graft survival in low-risk patients. And here are the different studies regarding induction therapies. And the question which still needs an answer is, do we still need interleukin-2 receptor as an induction therapy in the current use of conventional tacrolimus MF steroid? And the answer is, this should be individualized, particularly in the COVID era. As you see here, those are the incidence of different immunosuppressive. This is the ATG. Use is from 40 to 80% of cases, and the interleukin-2 receptor antagonist is the blue line, and no induction is the red line. This is calcineurin inhibitors. The green line is the tacrolimus, and the violet light, this one is cyclosporin. This is MMF, and this is azathioprine, and this is steroids in the first year, and this is steroids after the first year. And here are the rest of guidelines regarding maintenance immunosuppression, that we should use a combination. We should use a combination of CNI and antiproliferative and steroids. The CNI is recommended to be tacrolimus, and antiproliferative should be mycophenolate. And by that time, they said the TOR inhibitor should be delayed after the graft function is established and surgical wounds are healed. But now we don't do this, because by that time, early in 2009, they used sirolimus, which were used in loading doses and had effects on wound healing. And this is a very important paper published a few years ago about tacrolimus withdrawal in immune quiescent kidney transplant recipient. Tacrolimus withdrawal in immune quiescent kidney. What does it mean, immune quiescent? Low risk, living donor, first kidney transplant, negative cross match, no DSAs, clean biopsy, no inflammation. So they started by induction by ATG, followed by tacrolimus MF and steroids for 6 months, and then when they do the protocol biopsy and they found no activity and no inflammation, they randomized the patients either to continue on tacrolimus or to withdraw tacrolimus. And what was the result? Premature termination. Why? Because increased incidence of DSAs and increased incidence of acute rejection. And the conclusion was, tacrolimus withdrawal is strongly discouraged in kidney transplant recipients, even in low-risk patients. And this is the ELITE Symphony study, which compared the conventional cyclosporin, MF, and steroids without induction versus induction plus low-dose tacrolimus, MF steroids, low-dose cyclosporin, MF steroids, low-dose sirolimus, MF steroids, and the result was tacrolimus, the best incidence of acute rejection and the best GFR and the most safe. And those are the two TOR inhibitors which are commonly used, although they are structurally very similar, yet there is pharmacokinetic and pharmacodynamic differences between them. And this is the TRANSFORM study, which Dr. Pasquale is one of the main authors, and they compared the everolimus plus low-dose calcineurin inhibitor versus the conventional MPA CNI steroids protocol. They give induction at the beginning, and then they use this everolimus plus low-dose CNI versus the convention. The withdrawals and discontinuations were more in the everolimus group than the conventional group. And the primary endpoint, which is the incidence of acute rejection, and GFR less than 50 was a bit higher in the everolimus group than the conventional group in the intent to treat patients. Same for biopsy-proven rejection was a bit higher in the everolimus group versus the conventional group in the full set analysis, and lower in the compliance set. And here is the GFR, a bit higher in the conventional calcineurin MMF protocol versus the low-dose everolimus protocol. What about the side effects? As you see, here is the everolimus and here is the MPA. You can find that the incidence of proteinuria was higher in the everolimus, and as we expect, same as dyslipidemia. But what about the viral infection? It was much lower in the everolimus group versus the conventional group regarding BK virus and CMP. And there are several papers about the role of TOR inhibitors in malignancy, but then came this study from Heidelberg, which showed that the only difference was in non-melanoma skin cancer. There was lower incidence of non-melanoma skin cancer with the use of TOR inhibitor versus non-TOR inhibitor. But the rest of cancers, there was no significant difference. And this is a patient on cyclosporin azathioprine steroids who had viral warts, human papilloma virus, and this is the result after the treatment with rapamune and imiquimod, resolution of the warts. So TOR inhibitors out of transplantation are wonder drugs. They have anti-tumor, anti-atherosclerosis, inhibit the viral replication, but regarding transplantation, it has mixed and maybe some disappointing results. Steroid-sparing regimens may not benefit transplant recipient. This is true, and this is the paper which proved this. And you see here, this is the steroid withdrawal, and this is the steroid continuation, and there is increased incidence of acute rejection in the steroid withdrawal. And the increased incidence of CAN, chronic allographic nephropathy, in the steroid withdrawal. And there was no difference regarding hyperglycemia in both groups. But the only difference was in the avascular necrosis and fractures. It was much higher in the steroid continuation than the steroid withdrawal, as Professor Tariq Elbaz has just mentioned. And those are the monoclonal antibodies. They can be murine, can be chimeric, humanized or human. Rituximab is an anti-CD20, and it is used in desensitization, treatment of antibody-mediated rejection, and the big question mark on chronic antibody-mediated rejection. And here, and this is a new article published by Stanley Jordan in 2019 about the novel agents. And as you can see, this is the obinutuzumab, which is a new anti-CD20. It is fully humanized because rituximab is chimeric, and it produces more complete B-cell depletion. It is FDA approved in chronic lymphatic leukemia, and also is expanding in the treatment of lupus, systemic lupus. It is given in 2 doses, 1 week apart, and tried in desensitization in 2 or 3 doses as well. Regarding interleukin-6, this is Actemra or tocilizumab, which is interleukin-6 receptor antagonist, and it is a humanized anti-interleukin-6 antibody. It is approved for treatment of rheumatoid arthritis, and it is given in a dose of from 4 to 8 milligrams per kg. But clazakizumab is the inhibitor of the interleukin-6 cytokine, not the receptor, and it's more powerful than tocilizumab. And here is the IgG degrading enzyme of Streptococcus pyogenes aedes, which we are mentioning in few minutes. Here, this slide shows you the different effects of interleukin-6 regarding inflammation, T-cell activation, B-cell activation, and plasma cells. And here they tried interleukin-6 receptor antagonist tocilizumab in difficult to desensitize patients. There were 10 patients which were difficult to desensitize, didn't respond to a combination of plasmapheresis, IVIG, and rituximab. They gave them tocilizumab in a dose of from 4 to 8 milligram per kg from up to 6 months. And as you see, those are the DSAs before tocilizumab, and those are the DSAs after tocilizumab. And the result was a transplantation of 50% of the cases which were never going to be transplanted by the standard of care methods. What about tocilizumab in chronic antibody-mediated rejection? When we come to chronic antibody-mediated, there are more questions than answers, and the survival, the kidney survival at 2 years in untreated cases is almost 20%. And you see here, this is the glomerulitis plus the peritubular capillaritis score before tocilizumab, and this is after tocilizumab decreased marvelously. Here is the C4D, also deposition has decreased after tocilizumab, but the transplant glomerulopathy score was not different. And you see the graft survival in 6 years regarding the chronic antibody-mediated rejection is almost 80%, and a bit lower in transplant glomerulopathy. And here is the patient survival at 6 years as well. What were the adverse events? 5 cases of CMV out of 36, 2 cases of BK, and one, this is a benign skin lesion due to BK, which was resolved after stopping tocilizumab, and there were 7 cases of bacterial infections. And how did tocilizumab work? Through inhibition of the IgG and the different IgG subclasses and the anti-HLA antibodies. Bortezomib is a proteasome inhibitor that is against plasma cells, and the result is failure. This is not a success. Is not well tolerated and only associated with mild reduction of anti-HLA antibody. This is a strong study on 666 patients published in 2016 by Flavio Vincenti and others, and they compared the less intensive belatacept dose versus the more intensive belatacept dose versus cyclosporine. And this is the cyclosporine arm had the least survival, and the other belatacept 2 protocols had the better survival. And this is the GFR, this is cyclosporine, and this is the belatacept. Cyclosporine has less GFR than the belatacept. And this is the DSA. Cyclosporine had higher DSAs than the belatacept groups. But what is the Achilles heel of belatacept? Number 1, the incidence of acute rejection. Number 2, the incidence of CNS lymphomas in Epstein-Barr virus negative recipients. You see here the incidence of acute rejection in the belatacept is much higher than in the cyclosporine. Different types of rejection is higher here. And this is the DSAs in the belatacept versus cyclosporine in a post hoc analysis published 2018. This is cyclosporine highest DSAs versus the 2 other belatacept groups. And what is the solution? The solution is to combine belatacept with tacrolimus. They tried the combination for 3 months, but still the incidence of rejection is high. They tried 6 months, still high. But when they tried from 9 to 11 months, the incidence of rejection is comparable. So if you want to use belatacept, use it with tacrolimus for prolonged period of 9 to 11 months. And this is a question, is belatacept a success or failure? It provides a CNI-free regimen. It preserves kidney function, less DSAs, and assures compliance because it is given by IV injection. And what's new in the pipeline? The anti-CD40. The new anti-CD40 monoclonal antibodies demonstrate comparable efficacy and better renal function versus tacrolimus in de novo CNI-free kidney transplantation. And here is eculizumab in chronic antibody-mediated rejection, just better GFR than the standard of care treatment. And here is the C1 esterase inhibitor for acute antibody-mediated rejection as well. And what about the new treatment options? It is the IgG endopeptidase in highly sensitized patients. This is a breakthrough in the field of kidney transplantation. You see here the IDES, which start cleaving the all forms of IgG antibodies, partially and totally. And here are the two protocols, one from Sweden and the other from USA. And the one from Sweden, they used induction horse ETG. And why horse, not rabbit? Because IDES cleaves the rabbit as well. But the USA used alemtuzumab 4 days after IDES to avoid the cleavage of IDES to the alemtuzumab. And these are the MFI of the antibodies before the IDES, and the blue color is after using the IDES. In few hours, the DSAs disappear. And here is the C1q antibodies, high, and after the IDES, it disappeared. And this is before the IDES, the DSAs are high, and then they disappear, but there is rebound. Within from 7 to 14 days, there is the rebound. And so the weaknesses of the IDES is the rebound, and is the immunogenicity because you can use it, you cannot use it several times, and that it cleaves all antibodies, the good antibodies and the bad antibodies, including IVIG and rituximab. And this is a new study by Montgomery in application of the IDES. And what did he do? All patients were positive cross-match, whether diseased or living, and then they gave the IDES, and the cross-match became negative. So the strength of the IDES is that it converts positive cross-match into negative cross-match in few hours. And then Montgomery gave alemtuzumab 4 days from the IDES in order to avoid its cleavage, and then VIG by 7 days and rituximab by 9 days, and this allowed transplantation of cases which were impossible to be transplanted because of the positive cross-match without the IDES. And what about the conclusions? We need updated guidelines to guide us regarding induction therapy. We need new endpoints that focus on longer-term graft survival and function. We need to develop equally effective co-stimulation blockade. We should target innate immune mechanisms that contribute to the ischemia reperfusion engine. Thank you so much.
Hi, evening everyone. My name is Georgia Jordan, and I'm one of the pharmacists from Imperial College Healthcare NHS Trust in London, like Frank, who kindly presented a short while ago. And what I want to do is just take some time this evening to chat to you about our experiences at Imperial about switching patients from branded to generic immunosuppression. So what I want to do is I'll give you a little bit of background into the reasoning that we undertook this project. I just wanted to set some objectives and the timeline of the project and how we planned the project and the approach that we took. I wanted to chat to you about the outcomes and the lessons learned and actually what we need to do looking ahead. So a little bit of background information about Imperial. So the West London Renal and Transplant Centre is part of Imperial College Healthcare NHS Trust. And we're a trust made up of 5 hospitals across North West London, and we're based in Hammersmith Hospital. We currently average around 170 transplants a year. That's increasing year on year. I think if I got the data right last year, then we've done 239, which is our peak. And since 2010, we've undertaken around 2,000 transplants. The use of generic immunosuppression in place of brand name immunosuppression offers considerable cost savings. Adaport is an immediate release, twice daily oral tacrolimus preparation, which was introduced into the UK in August 2010 and was introduced as our trust's first-line oral immunosuppression in place of Prograf, which is the originator product, in 2011. Now, although bioequivalence with Prograf has been demonstrated for licensing purposes, historical guidance on the substitution of generic immunosuppression drugs has highlighted the possibility that the relationship between the exposure to the drug and the surrogate marker may vary between formulations, particularly in routine clinical practice. And the narrow therapeutic index of tacrolimus and the potential adverse consequences of subtherapeutic and toxic concentrations necessitate close monitoring of patients' exposure to drugs. Now, the Trust undertook a large branded to generic immunosuppression switch project back in 2011. However, last year in 2019, it was identified that there was still a large number of patients maintained on branded immunosuppression, so Prograf, which totaled an annual spend of over £500,000 a year. And the Trust noticed that this was a significant cost-saving opportunity, and I was seconded into post to undertake the project. The project actually involves all branded immunosuppression, so Prograf, Cellcept, and Neoral, but I will focus this presentation purely on the Prograf to Adaport switch. Now, as I mentioned previously, we undertook a similar project in 2011, where we obtained annual savings in the region of £500,000. And since then, we've been left over with a cohort of patients that, one, either refused to switch in 2011, or have just kind of slowly reverted back to Prograf since the switch. And as we're still currently spending around £500,000 a year, and this was a good opportunity to revisit the cohort with a new project. Now, although the switch project undertaken at Imperial in 2011 was large, we've got sample population data relating to 156 patients, where the average change in tacrolimus levels was an increase in 0.08, and around 14% of patients' tacrolimus levels increased by 2 points, and just under 15% of patients' tacrolimus dropped by 2 points. Now, unfortunately, there was no data on the number of patients that actually required a dose change following the switch. However, the previous data highlighted that caution and close monitoring would be required in patients who are at the top or bottom end of their tacrolimus levels. Now, the primary driver objective was based around financial savings, with annual estimated cost savings of around £320,000 a year if 100% of these patients switched to what we call the generic immunosuppression. There was also a small secondary driver, which was non-financial, and it was a case for change, which was switching patients to modified release preparations of tacrolimus, such as Advagraph or the newly introduced to the UK Dailyport, if necessary to aid adherence in these patients. Now, a brief timeline onto the slide in front of you. And as you can see at the beginning, sorry about that. I spent a month planning the project, which involved a primary literature set on other centres' experiences in branded to generic tacrolimus switches, and also reviewed the processes and data from the previous switch project in 2011 and refined the process. Now, as you can see, in March 2020, the pandemic forced us to suspend the project entirely. And towards the middle of this year, so July, August time, I attempted using virtual mediums to restart the project. And I'll discuss the drawbacks of this later in the presentation. So in order to plan for the project, I used the Trust's e-prescribing and dispensing data from the past 3 years to ensure that I captured all the patients who'd been taking Prograf over the past 3 years. 278 patients have been identified as taking Prograf, totaling an annual spend of £537,000 a year. I then reviewed each patient individually to check that actually they were still taking the Prograf, because like I said, this data was captured over 3 years, and also identified the location of each patient across the trust, and highlighted that these patients spread out over 16 geographical locations, making the project a little bit tricky. And after applying exclusion criteria, which I've placed on the screen, identified 262 of these patients were suitable to switch to generic immunosuppression, with potential annual savings of the £320,000 a year if they all switched across. Now, during this process, I identified that some patients had trialed taking Adaport in the past and had switched back to Prograf. And for that reason, these patients were kind of costed as if they were going to switch onto Advograph rather than Adaport. Now, once all the relevant patients had been identified, it was time to start physically seeing the patients, the exciting bit, and discussing the switches with them. And the biggest change that I introduced was the patient's journey through outpatient clinic. And this was the introduction of actually the patient seeing a pharmacist before the doctor to discuss the switch. And as part of this consultation, I explained the rationale to the patient. So, explained to them a little bit about the primary literature, why we're doing it, explained the safety of the switch based on the previous data that we've had, and again, the primary literature, explained how we're going to do the switch. So they'll continue to take their branded immunosuppression up until 1 or 2 weeks before their next outpatient appointment and blood test, and then stop taking their Prograf and switch on to taking their Adaport or Advograph if necessary. I also explained the cost savings and safety netted as well, decided on a switch date and provided a prescription, and then documented the dates and followed up the patients a day post their level to check their levels, and also audited the results. Now, the outcomes, probably the bit that you wanted to get to. So between January this year and mid-March 2020, I discussed switching patients to, switching to generic immunosuppression with 119 patients. And 104 of these agreed to switch kind of pre-COVID with annual savings of £135,000 a year. Now, since then, 58 of these have physically switched to Prograf, switched from Prograf, sorry. And the remaining 43 still actually require a new date to switch across. But what we're finding at the moment is that clinicians and patients are reluctant to reinitiate the switch in view of consistently changing pandemic updates and the risk of balancing patient exposure to the hospital environment and obtaining tacrolimus levels. We found that around 5% of patients actually switched back from Prograf due to intolerable side effects, which they all explained as being GI upset. Around 12% actually refused to switch from their branded immunosuppression, and this was for a range of reasons. Majority of them being the fact that they had tried Adaport in the past and were not prepared to try another brand of immunosuppression at all. Some of them outright refused to switch and would not provide us with any reason why. It was just a clear, I am absolutely not doing it. Some were worried that the brands would cause worsening of renal function, and some were actually worried about the colour differences in the capsules. Now, unfortunately, the data that we have is only based on small numbers from the 2020 project. And the average tacrolimus level change in patients switching from Prograf to Adaport with an increase in 0.39. And the average tacrolimus level in patients switching from Prograf to Advograph was minus 0.03, but the cohort of the Advograph is very, very small, which is why the standard deviation is so large. So as a result of the small amount of data that we've got from the 2020 project, the statistical significance of the results actually could be challenged. And therefore, I've compared my results with the data that we've got from 2011 in a larger population to test the consistency of our findings. So when we compare this to the previous project undertaken in 2011, the average change in tacrolimus levels from the previous project was plus 0.08. And what I wanted to do was compare our data to that of the primary literature. And I've referenced the studies at the bottom of the slide here. So one study reported that around 15% of patients had an increase in tacrolimus levels more than 2 points. And this was similar to the data that we observed in 2011. And perhaps if we had a larger population this year, our results may be more relative. But for now, this year, we're finding that around 6% of patients' tacrolimus levels decreased by more than 2 points, and around 8% of patients' tacrolimus levels increased by more than 2 points. Now, in another study, dose titrations occurred in around 21% of patients, whereas for us at present, we're observing dose changes in around 15% of patients, which mainly occurred in patients that were either at the top or lower end of their tacrolimus level range. So what went well and what didn't go well? So what went well is that we actually exceeded our prediction in the target number of patients that we aimed to switch before April 2020. And this highlighted that the process that we had was robust and was established enough to withhold the amount of patients that were coming through. It also solidified our experience that branded to generic immunosuppression switches are safe when monitored closely 1 to 2 weeks post-switch. Unfortunately, the things that didn't go well was the pandemic. It put an abrupt halt onto the switch program, and now patients are completely reluctant to switch until the pandemic's over. There was a lot of resistance from patients, which was expected, because a lot of these patients were the patients that kind of refused last time. And there was a bit of aggression from patients as well, because they'd always been told that they should always stay on the brand of immunosuppression that they were told at the beginning. Surprisingly, the dialysis cohort were particularly difficult to switch, because we expected them to actually be the easiest cohort to switch across. For me personally, Northwest London has a large ethnic diversity, and for me there was a big language barrier with only being able to speak English. Later, when I started to reinitiate the project, we identified that virtual mediums do not work well here, because certainly where we work, it's unusual for patients to come and see a pharmacist in clinic. Normally their route through clinic is doctors and nurses, and they didn't really know who we were. So it appeared as if we were cold calling them. And what we found is that most patients truly just wanted to speak to their consultant before making a decision to switch, which slowed down the process considerably, and actually was just a lot of duplication of work. And like I said, we had a small population data as well. So looking ahead, our remaining cohort is still large. Despite having a good approach at the beginning of the project, this approach is actually no longer feasible when we're minimizing the amount of people who come to hospital. We're having to use virtual mediums where necessary, and we found that patients respond better actually to their doctors telling them to switch rather than pharmacists. So looking ahead, our new approach really needs to be consultant driven. And we've recently actually had the introduction of Dailyport in the UK. And this is a generic once daily modified release preparation of tacrolimus, which has been manufactured by Sandoz. And this is shown bioequivalence to Advagraph, and also provides additional cost savings for people who require a once daily formulation due to adherence concerns. And just to conclude, we know that tacrolimus is a calcineurin inhibitor and is the cornerstone in most immunosuppressive regimes today. Pharmacological bioequivalence has been demonstrated for the immediate release twice daily formulation of generic tacrolimus with 90% confidence intervals for the relevant parameters, including area under the curve and Cmax. The current opinion among the transplant community is that the use of generic immunosuppressive therapy in preference to branded drugs is safe, but certain precautions are needed, including stringent therapeutic drug monitoring during the initial switch phase, And this is supported with the data that we've obtained in 2011 and 2020. So in light of this, we've proven by meeting our objectives that you can implement a successful switch program, providing significant savings for the benefit of the trust and the community, whilst maintaining safety and in some situations enhancing medicine adherence for patients. So thank you all for your time, and I'll leave it there.
I think, thank you very much, Dr. Georgia, for this very illustrative talk. And I think we have exceeded the time of the meeting, which was supposed to be finishing by maybe 40 minutes ago. So unfortunately, we will delay the questions, and we will try to send the question by mail or by WhatsApp to different speakers because of the shortage of time. Thank you all for this wonderful night that was shared by from Spain, from France, from UK, and from Netherlands also, because Dr. Frank Door originally from Netherlands, and from Egyptian colleagues. And thank you, Sandoz, for hosting this night. And stay safe in this COVID time, and hope to see you in Egypt afterwards. Thank you very much.
Thank you. Thank you.
Thank you.
Thank you.